चेंज बैकग्राउंड सही नहीं आ रहा ना. क्या करना. इसको यहाँ कर देते हो ना. यहाँ कर दिया मैंने इमेज को. स्टार्ट कर दे. So very good afternoon, students. Today we are going to discuss the recall questions of the FMG exam that just happened, right? There was mixed reviews, but regarding pediatrics, short questions were there, right? The last session that we discussed 20 short topics, almost 90% of the questions were from those topics, right? Which is a good score. So firstly, let's begin with discussing the question. The first question is a milestone question. Again, a very expected question that they will give at least one question from the milestones, right? So let's see what they have asked this time. They asked that this is a child that can sit with support and transfer objects from one hand to the other. What all milestone can be seen at this age? We know sitting with support comes at 6 months. And transferring of the object is also around this time, 5 to 6 months, right? And the options were pincer grasp, child responding to the name. So both of these options seem correct to me, right? Pincer grasp, we all know immature comes by 9 months and mature comes by 12 months. What is this? This is the mature pencil grasp or a immature pencil grasp? Okay, sign is made, right? So this is a mature pencil grasp. And name responding also comes around 7 months of the age. So depending upon what all scenarios were given, you have to mark the appropriate answer. So the crux is that milestone is one such topic that you cannot afford to miss. Just before the exam you have to brush up through, right? Moving down to the next question, they gave a child with mental retardation single palmar crease and they asked for the diagnosis, right? Mental retardation single palmar crease, also known as simian crease. This is nothing but Down syndrome. This is nothing but Down syndrome, right? So let's discuss some features of the Down syndrome over here. What is the most striking feature when you see a Down syndrome child? It is hypotonia. Hypotonia is the most striking feature. We will now go from head to toe, right? Firstly, head, there will be mental retardation. Mental retardation is universal in Down syndrome patients. In eyes, you see a lot of feature. What do you see? You see epicanthal folds. In the iris, you see brush felt spots. There is a typical Mongolian slant. What is Mongolian slant? That the outer canthi of the eye would be up as compared to the inner canthi. This is the Mongolian slant, right? Apart from that, in hands you will see simian crease, that is a single palmar crease. Sometimes fifth finger clinodactyly, that my fifth finger would be abnormally large like a claw, right? This is clinodactyly. We can see various heart defects. Most common is the endocardial cushion defects. In gut, we can see intestinal atresia, duodenal atresia, Hirschsprung disease, annular pancreas, and in foot we see a sandal gap. Sandal gap. What is sandal gap? There would be a gap in between the big toe and the other toes. This is a sandal gap. This is what we see, right? Apart from that, we know these children with Down syndrome also have high risk of hypothyroidism, high risk of atlantoaxial dislocation. That's why we screen and do neck x-ray at 3 to 5 years of age. Also, these children have high chances of developing leukemias as compared to the normal population. Most common is ALL. ALL M7 is more common in smaller children, less than 3-year-old children. Also higher chances of pre-senile Alzheimer's disease, because the APP, that is the amyloid precursor protein responsible for this Alzheimer's, it is on 21st chromosome, and in Down syndrome we have one extra 21st chromosome, right? So more chances of pre-senile Alzheimer's disease. Apart from that, low IQ and developmental delay, as I mentioned earlier, is universal, right? So this is about Down syndrome. We all know what is Down syndrome. It is aneuploidy. What is aneuploidy? Where there is difference in the number of chromosome. Here we have one extra 21 chromosome. Okay. Moving down to the next question. They gave a scenario with the child with gynecomastia, testicular atrophy, and again they were asking the diagnosis over here. Most likely here the answer is Klinefelter syndrome, right? Little about Klinefelter syndrome, you again know this is an aneuploidy. What extra do we have? We have an extra X chromosome, so we have 47 XXY, right? So this is a male child with one extra X chromosome. It is actually the most common sex chromosome disorder. What are the features that you are going to notice here? The child is going to have a tall stature, reduced muscle tone, weakened bone, gynecomastia, abnormal behavior abnormalities and development abnormalities. All of these could also be seen, right? Infertility and enlarged breast tissues. This is the pointer over here, right? Moving down to the next question, question number 4. So they gave a scenario like a diabetic mother gave birth to a child. After 2 to 4 hours of the birth, blood sugar monitoring, I guess, was asked, right? They ask about, I think, the cutoff of the neonatal hypoglycemia. Infant or diabetic mother, anyways we have to screen for hypoglycemia. Why? Because inside the womb, what was happening inside the womb? Mother was diabetic, so there was hyperglycemia in the mother. That hyperglycemia was transferred to the baby. That means hyperglycemia in the baby also. So the baby, to counteract that hyperglycemia, makes more and more insulin. So hyperinsulinemia in the baby. This hyperinsulinemia is responsible for the growth of the baby, anabolic hormones. That's why infants of diabetic mother are large for gestational age babies, right? The problem happens post birth. After birth, when we cut the umbilical cord, now the high supply of glucose is cut, right? So there is chances that the baby can land up into hypoglycemia after birth, right? So that's why we monitor these babies for hypoglycemia. And what is the cutoff for neonatal hypoglycemia? It's 45 milligram per deciliter, right? So two hypoglycemia I want you to remember. One is this neonatal hypoglycemia. Second hypoglycemia is in the SAM child. There the cutoff is 54, right? Moving down to the next question, a short stature question. In my 20 short topics, one of the initial few topics were short stature, and even in the revision module that is available on YouTube, there also we discuss short stature in detail, because at least one question is expected every time they ask the short stature question, right? So what they asked this time, they gave a 12-year-old child and told that the height for age is less than -2 standard deviation. That is the definition of short stature. They gave the upper segment lower segment ratio as 1.1:1, and they also gave you a clue that the family history of short stature is there, and options were like constitutional delay in growth and puberty, familial short stature, achondroplasia, right? So let's see what would be the most appropriate answer over here, right? So short stature we have confirmed, because the height for the age is less than -2 standard deviation. What about this upper segment lower segment ratio and the age? What about this upper segment and lower segment ratio? What is the normal upper segment ratio at birth? At birth, it's 1.7:1. At 3 years of age, it's 1.3:1. At 6 years of age, it becomes close to 1.1:1. And at 10 years, it becomes the adult ratio, this, right? So this is a child who is 12-year-old. So this child should have an adult ratio. What is the adult ratio? Adult ratio is 0.9:1. But here the ratio is increased Here the ratio is high, upper segment lower segment ratio is high. That means my upper segment is big, lower segment is short. This is short limb dwarfism, short limb dwarfism. And I don't know how many times in my recall session and revision sessions I have told you that whenever a short limb dwarfism is there, whenever there is higher upper segment lower segment ratio, then you should remember three conditions. What are these three conditions? Rickets, achondroplasia, rickets, achondroplasia and congenital hypothyroidism. Congenital hypothyroidism. Right? These three conditions you cannot afford to miss. Right? You should remember these three conditions even in your sleep. What are the three conditions? Where there is high upper segment lower segment ratio or short limb dwarfism, rickets, achondroplasia and congenital hypothyroidism. Right? Out of these three conditions, they gave a family history, right? Important point over here. Rickets cannot be familial, most of the cases not familial, right? It is due to nutritional deficiency most commonly, right? Same goes with congenital hypothyroidism. If congenital hypothyroidism would be an option, then definitely they would have mentioned mental retardation also, weight gain also, other features also, cold intolerance also, right? So the most appropriate answer here is achondroplasia, right? This familial short stature and constitutional delay, these are the physiological causes, and here the upper segment and lower segment ratio would be normal, not that affected, right? That is affected in pathological short stature where you see disproportionate short stature, right? So here the important topic is this. We have covered short stature in detail in the 20 short topics, also in the revision module also, right? So I hope you have marked this correct as achondroplasia, right? If the scenario was like this, most appropriate answer would be achondroplasia. Moving down to the next question, a causative agent of hand, foot and mouth disease, right? No brainer question, very commonly repeated question. It's Coxsackie. Coxsackie virus, A16, most common cause of hand, foot and mouth disease, right? Then they gave this chest x-ray. This chest x-ray also we discussed in the 20 short topics, right? A lot of chest x-rays I discussed of congenital heart disease, different congenital heart disease, and one of them is this, most commonly asked. What is this? This is nothing but boot shaped heart. And where do you see this boot shaped heart? We see this boot shaped heart in TOF, tetralogy of Fallot. What do you see in TAPVC? In supracardiac TAPVC, you see figure of 8 appearance or snowman appearance, right? In ASD, no such X-ray typical finding is there, and same goes for VSD, right? So the most important congenital heart disease TOF is asked over here. They gave a simple X-ray, boot-shaped heart, pointer, TOF, right? Moving down to the next question. This next question is not that complete, but there was something asked about the Tanner staging, right? And either they could have asked the growth spurt or they could have asked some peculiar finding. So let's just discuss Tanner staging over here. We all know Tanner staging. Why do we use Tanner staging? We use Tanner staging to grade the puberty. What is adolescence? Adolescence is an age group, right? A growth phase age group 10 to 19 years. What is puberty? Puberty refers to the appearance of the secondary sexual characters, and we grade this by Tanner staging, also known as sexual maturity rating staging or SMR staging, right? Staging is different in females obviously and males. In females, we have 5 stages. For pubic hair also 5 stages, for breast development also 5 stages. Stage 1 would be the pre-adolescent stage where nothing is developed, no sexual feature you can see. And stage 5 would be adult-like feature, right? So very easy to remember. Pubic hair would be none in stage 1 and would be adult-like feminine distribution, right? And the spread of this pubic hair would also be to the medial thigh. In breast development, in stage 1, it will be pre-adolescent. In stage 5, the breast development would be mature, nipple will project and the breast contour would be well developed. Right? Now let's talk about the in-between stages. Firstly, let's talk about stage 4. Stage 4. Why I am going to stage 4? Because stage 4 is very easy to remember. I told you that in stage 5, adult-like pubic hair distribution would be there, feminine pubic hair distribution and also spreading to the medial thigh. In stage 4, the hair distribution, pubic hair distribution would be adult-like, but no hair would be there on the medial thigh, right? So curly abundant adult type would be there, but no hair on the medial thigh, right? Now we have remembered stage 1, stage 4 and stage 5. Now stage 2 and 3 is very easy. Stage 2, we will have very scanty hair, and these hair would be very thin straight hair just around the labia, just around the medial border of the labia. In stage 3, now these scanty straight thin hair will turn dark, start curling and small amount would be seen. Right, so pubic hair in females, very easy to remember. Stage 1, stage 5. Stage 1 is no pubic hair. Stage 5 would be adult pattern of distribution and also present on the medial thigh. Stage 4 is similar to stage 5 but no hair on the medial thigh. Stage 2, there would be very thin straight hair only on the medial border of the labia, right? And in stage 2, there will be curling, starting of the curling of the hair will start darken, thicken, right? Now let's move to males. In males, apart from the pubic hair, we take penis and testis into the picture. The pubic hair is similar to that of the females. 1 would be none, 5 would be adult pattern along with the medial thigh involvement, 4th would be adult pattern without the medial thigh involvement, 2 would be very scanty hair, thin hair, long hair, and 3rd would be very coarsening of the hair, curling would start, right? So this is all about pubic hair, very similar to the female ones. Let's talk about now penis and testis. For penis, again stage 1 would be the pre-adolescent, and stage 5 would be adult size. Now what would be the stages 2, 3 and 4 in between? In stage 2, there will be just a minimal enlargement of the penis, very minimal enlargement. In stage 3, now the penis would lengthen. The penis lengthens first and then broadens, right? So in stage 3, there will be lengthening of the penis, and stage 4, now there is broadening. The breadth will increase and finally it will reach to the adult size. So penis is also very easy to remember. 1 and 5 similar, pre-adolescent and adult. In stage 2, minimal enlargement. Stage 3, there will be lengthening and then there will be broadening, right? Moving down to testes. Testes, again stage 1 and 5 we all remember. Stage 1 is pre-adolescent stage. Stage 5 is adult. In between, there stage 2 and 3 and 4, initially there will be enlargement, then further enlargement, and then scrotum will become darker, right? So depending upon what all they asked, you would have marked that correct stage. Most commonly they ask at what stage height spurt was there, but as I confirmed with some of the students, they said that no ma'am, they didn't ask about the growth spurt. It was something else. So if they asked about the height spurt or growth spurt, then in female it is in the early puberty, stage 2 and 3, and in male it is in the late puberty, stage 3 and 4, right? So this is the most likely questions that could be made out of Tanner staging, right? Moving down to the next question, it was something about the prolonged jaundice, congenital jaundice, right? Jaundice staying for a long time. Whether it was direct component or indirect component, that you have to tell, right? So let me discuss what could be the possible options over here. So when we talk about neonatal jaundice, then they could either be prolonged neonatal jaundice, they could either be unconjugated or conjugated. Very easy to remember the causes, unconjugated and conjugated, right? Let's first talk about unconjugated. In unconjugated, you have to remember two disorders, Rigler-Najar and Gilbert. We all know which enzyme is responsible for conjugation? UDP-GT enzyme. So what happens in regular Najar syndrome? We have two types, type 1 and 2. In type 1, which is the severe type, here this enzyme is absent. Here this enzyme is absent, so there will be severe jaundice, there will be kernicterus. The treatment modulation here would be liver transplantation, nothing else. What happens in type 2? The enzyme is there, but the activity of the enzyme is low, right? So here the severity of the jaundice will be low. There won't be kernicterus chances, but definitely pathological jaundice would be there. Here we give phototherapy, and we can also try phenobarbital, as phenobarbital is an enzyme inducer and can increase the activity of this UDP-GT enzyme. Moving down to the second cause of the inherited hyperbil, unconjugated type, Gilbert. Here also there is decrease in the activity, but this is very intermittent. As with illness, it is precipitated by illness. When the child will fall sick, the activity of this enzyme will decrease and the child is going to have jaundice. Nothing has to be done here, just supportive treatment, right? Moving down to the conjugated picture, we have Dubin-Johnson and Rotter syndrome. Both of these similar presentation, direct component would be increased, but the defect is different. What is the defect in Dubin-Johnson? It is MDRP, that is multi-drug resistant protein 2, and here it is OATP, that is organic anion transporter protein. How we differentiate them? By the liver biopsy. In Dubin-Johnson, there is dark pigment deposits, and in Rotter syndrome, the liver biopsy appears normal. And urine porphyrin is normal in Dubin-Johnson and high in Rotter. So try to recall what all things were given over here. If it is with direct, then the options would be out of these two. If it was indirect, options would be out of these two, right? And if it was a severe jaundice, kernicterus, then more likely it is type 1 regular Najar, right? And if it was not severe jaundice, just pathological jaundice, unconjugated jaundice, then the answer could be type 2 also, right? So depending upon the permutation combination what was asked, try to recall that, and that would be the correct answer. Important here is to understanding the concept behind prolonged inherited jaundice, right? So that's all about the questions that I could have recollected from here and there. If there is any doubt regarding any of these questions, or if you want to add something to it, or if you want to give any feedback regarding any of these questions or any difference that was asked in the exam, you can just share over the comment section, and if not, then we can close the session. I hope pediatrics was a clean sweep for each one of you, because a lot of repeated questions, a lot of important topics that was recently discussed was asked again and again, right? If you would have just attended those 20 short topics, 90% of the questions are covered over here, right? So any doubt over here, any doubt or any different question that was asked in the exam? I think one rickets picture was also given with bowing of legs and widening of the wrist, right? That was a simple straight question. Calcium deficiency, vitamin D, nutritional rickets. Anything else? If not, we can end the session. Okay, thank you students. We can end this session now.